Okay, so welcome to the August 22nd Medical Advisory Committee Run Review. These are two interesting cases. I like them a lot. As we go through it, you'll see some of the reasons why I've done things that I've done as far as treating hypertensive emergencies and why I don't necessarily think that unless you have the ability to do it in a controlled situation, treating hypertension in the field is always a good thing. I'm not quite sure. So, case number 1. Patient was last seen normal at 2100 hours the night before. Pretty straightforward. The roommate heard a noise from the patient's room and found the patient on the floor next to the bed. The patient was unresponsive with rapid breathing. So what are people thinking at this point about potential differential diagnoses? Come on, some.
It could be diabetes, it could be coming out of a seizure, it could be a whole bunch of things.
Okay, so I have, this is not the rhetorical part or question. So Mr. Maston says seizure, postictal, diabetes, they're hypoglycemic or they're hyperglycemic and they've gone into a non-ketotic coma. What else?
CV.
Yeah.
Stroke. So we're thinking stroke, hemorrhagic or ischemic. Could be either. Anything else? Anybody else? I feel like an auctioneer. Going, gone.
Could be an overdose, could be an underdose, could be
drunk.
Could be drunk, overdose. So basically, a boatload of possibilities. Okay. So what other history do you guys want? What diagnostic interventions do you want to perform at the bedside or floor side, and why?
We want a complete history.
Okay, so
Meds, allergies, history, previous.
okay, so medications, lisinopril, antihypertensive, no other meds, no known drug allergies. What diagnostics do you want to do at the, and why do you want to do them? What information are you going to gain?
Vitals.
Okay,
Vitals.
blood pressure 208 over 110, pulse rate 78, respiratory rate about 20, O2 sat 94%, and AccuCheck 112.
Pupils.
Oh, pupils. Pupils are pinpoint. Anything else you guys want to know, or is that enough to,
I mean, you could do 12 lead. Wouldn't hurt. You can do 12
I'd
lead.
hook them up.
12 lead is abnormal. It's got lots of ectopy. So, physical exam. Pupils are somewhere between 2 and 4 millimeters, but they're sluggish. Head is atraumatic normocephalic. No trauma to the head. Now, doll's eyes are not tested. This is one of the learning points. This would be a good test to do. Who knows what doll's eye is? Oculocephalic test. So if you're not worried, we'll go into it in a minute. Their GCS is that of the table here. 3.
Yeah, that's not good.
There is no posturing. So the way does anybody have any tricks to remember decerebrate and decorticate posturing?
Corticates turn up, the surface.
Yep. I remember decorticate is you're flexed at the wrist muscle, fists, and you're pointing toward your core. I'm simple-minded. I have to remember shit like that. No purposeful movement, and they did not check for Babinski, toes going up, which is normal response in all kids because their tracts are not developed. So here's oculocephalic doll's eyes. And so what's supposed to happen, and granted you don't do this if you're worried about a cervical injury, because if you do a doll's eyes and they have a cervical injury and then you pith them, patients' families get upset. So if you look at the central, eye is looking forward. You go to the left, the eye should start rotating to the right. If you go to the right, then the eye should start rotating to the left. So they really need to go in the opposite direction of what the head movement is expected. If it's absent or asymmetric, you've got a brainstem injury. Quick, dirty, takes about 10 seconds. Left, right, eye should. Nice little trick. So next comatose patient that you're not worried about C-spine, you can go into the ER and the doc will go oculocephalic, doll's eyes, I can't remember. So no tracheal deviation. Pulmonary exam, breath sounds are equal. Good chest wall excursion. No deformities, no bruising. Cardiovascular, regular rate and rhythm. Now, the PCR said non-tender to gentle palpation. So I take a little issue with that. How can you know it's not tender? Well, they don't posture. But if they're comatose enough, they're not going to do anything anyway. Back, unremarkable, no malformations, no evidence of trauma. So this is really actually interfacility transport. So it's a 51-year-old male, time on scene, 42 minutes at the hospital, transport time 123 minutes, and the girlfriend shows up and says, yeah, he's got high blood pressure, but guess what? He doesn't take his meds. No known drug allergies. So he's febrile. Do you think he has meningitis? I would say no. You can get a centrally mediated hyperthermia strictly from stroke. And this guy's CT is a mess. He's got a subarachnoid everywhere. He's got a subdural on the left frontal parietal, 5 millimeters. He's got a subdural on the right, measuring 8. And he's got a shift. So the right's probably a contusion. So it's not uncommon with people who have blood in their CSF to get a temp. Making this guy's CT even more entertaining is that his sulci, those little curves, are all blunted. So he's got signs of big time increased intracranial pressure. 8 millimeter midline shift towards the left. So he's herniating in front of you. Ventricles are small, again, because he's got increased intracranial pressure. No definitive evidence for skull fracture. The 12 lead is now an accelerated junctional. Oh crap. That's all central mediated, not from the heart. Lactic acid, he's been down a little bit. H and H are fine. Interestingly enough, his bicarb's a little low. So he's probably hyperventilating to get rid of some acidosis. And his anion gap, he's really acidotic. Glucose, whoop-de-doo. Urine-specific gravity, he's dehydrated. And his CK, he hasn't gotten rhabdo yet. And I say that as a party favor. So, one who's hypertensive long-term should not do methamphetamine. It causes spikes in your blood pressure, causes you to bleed in your brain. So his initial vital signs, his initial vent settings, not too bad. PCO2 is a little low, so he's been retaining. His PO2 is a little low. So here's where the blood pressure, so the initial blood pressure at the hospital is 154/87. And I probably would have stopped there. Entitle's a little low when you start looking later, but not too bad. They appropriately put this person on nicardipine. Try to prevent vasospasm from whatever's bleeding in his subarachnoid. Good waveform with a reading of 44. Propofol, to sedate him because he's on the vent. The more I deal with propofol and interfacility transports, I'm less and less a fan. Because I think propofol is a drug for somebody in the ICU. I have flight providers in the room who may disagree with me, but I think providers spend a lot of time chasing their tail with propofol.
Propofol's good for the trash.
Propofol's what?
It's good for the trash.
Okay, so my two flight providers agree with me that they don't like propofol.
Yeah.
Every time I've seen propofol used in an IFT, they chase their tail. Blood pressure goes too low, they turn off the propofol. The blood pressure goes too high, they turn on the propofol. Fentanyl and Versed are wonderful drugs. They're tried and true, and they work.
Ketamine's even better.
Thank you. I like ketamine too. Not for personal use, never use it personally.
Oh, it's good.
You've had ketamine?
Yeah.
Was it as much
was
fun as
good.
it's supposed to be?
I got to try it all. Versed, fentanyl, and ketamine. When I had my surgery, the anesthesiologist says, "Man, let me try it." He goes, "Here you go." It was sweet. You just don't go to Ketamine Island. 'Cause then you'll
Ketamine
get-
Island.
That's when they get psychotic. Yeah, if you get too much.
I like it.
So we did that.
I was on Ketamine Island, baby.
Yes.
That's
No, you don't want to go there. They say. I didn't go there, but it was sweet.
It's a magical mid-dose when they feel no pain, but they're awake enough to swing at you. Keep
Nice.
them under it or over it.
Anyway, it was nice.
So, fentanyl was given for pain. Pain was reduced to 0 out of 10. I did speak to the provider for a anonymous air provider. How can you say the Wong-Baker faces pain scale? Yeah, their vital signs got abnormal. And there at the bottom, they're chasing their tail with propofol. I should mention that this is not within this region. How about that? I'll give that little clue away. This is from an outside region. This is not NorCal. So they decreased the drip of nicardipine. And so here's the key, and this is why I've never been a big fan of treating hypertension in the field. Is some of us are old enough, because we get AARP failings, that I lived through the era where we used to give Procardia sublingual 10 milligrams. And what ends up happening is the ACA territory, the anterior cerebral artery and the middle cerebral artery, have an area between them called the watershed area, where both vessels kind of go in and kind of merge, but one is not more dominant than the other usually. And so what ends up happening is when you lower the blood pressure, suddenly these watershed areas, and there's another one between the MCA and the PCA, do not get perfusion. So if they're not getting perfused, what happens to that neural tissue? It dies. And if they're used to a high filling pressure like 200 over 110 or whatever it is, and you suddenly reduce them by more than about 20%, you either give them another new stroke or you make it so the current stroke will not respond. So here's another color representation of that. Because what used to happen in Procardia is you take somebody with a high filling pressure, you drop their blood pressure more than 20%, and they'd stroke in front of you. Really bad form. So, subarachnoid hemorrhage. Very interesting factoids. 10% of these aneurysmal, there we go, die before they reach the hospital. What's even scarier is 25% die within the first 24 hours, whether you've done anything right or wrong. And then there's the last piece, 45% of those surviving die within 30 days from infection usually, because they've been on the vent and they get septic and then they die. Or they get urosepsis from the Foley that's in them. So if you have a subarachnoid hemorrhage, only about a third have, quote, good outcome. Really very scary statistics. An acute blood pressure reduction, helpful or harmful? So you're balancing rebleeding, vasospasm, and delayed cerebral edema. So you want to bring the blood pressure down so they don't vasospasm, they don't rebleed, but it's cerebral edema and cerebral ischemia. But if you don't, then they get hydrocephalus, increased intracranial pressure, and then the brain can't perfuse. So you're kind of caught yes, no. I don't feel that pre-hospital providers have the tools to acutely take care of these people, where they need to acutely change their blood pressure. Because I've had lots of EMS providers who only have, say, nitro at hand. Well, if the patient's nitro naive and they've never had nitro before, you don't know what their blood pressure is going to do. And so if you're used to higher filling pressure, bad things happen. So the big things for treatment of these patients is hypoxia, metabolic acidosis, they're breathing fast, they're hyperventilating for a reason, hyperglycemia, so that's why you need to check a glucose, because if you're going to thrombolize them, then their glucose can't be over 400, blood pressure instability. Adding to the fun is when they get to the hospital, they're getting syndrome of inappropriate ADH secretion, so they're getting hyponatremic, which doesn't do things, and we've talked about central fever. The really bad thing about central fever is it responds to cooling blankets, but not Tylenol. So, you want to keep their cerebral perfusion pressure around 70 millimeters of mercury. The problem is, to really know what that is, you need a bolt in their head, which are these bolts they put in intracranial pressure monitor. That's what they used to call them. I don't know what they call them now. Because if you think about the brain, it's in a big square box. And you're balancing increased blood flow so they perfuse and the neurons don't die, but with too much blood flow, your brain expands and it gets squished. If you push up the pressure too much, then it goes down that hole at the bottom of your skull called the foramen magnum, and then they herniate.
Spillway.
Yeah, it's Oroville Dam on steroids. I like that, spillway. I never thought of it like that. So, optimal treatment of hypertension, subarachnoid hemorrhage is not 100% clear. We reflectively see hypertension and want to treat it, and that may not be a good thing. Here are the guidelines, 2012 guidelines from the American Stroke Association. 160. You avoid nitroprusside or nitroglycerin because it increases cerebral blood volume. Why? They're both vasodilators. So the veins go up, more blood, more volume, more squeeze. Shit. So as you increase your cerebral blood volume, you get increased intracranial pressure. You're using drugs that really should be like labetalol, nicardipine, and enalapril. Now, if they've had a subarachnoid, you can give nimodipine to prevent spasm, but that's a hospital thing. So you're balancing fluid resuscitation versus hypertension to keep the increased cerebral perfusion. That's why these people die, because they're tough. So that's why you really need to look at mean arterial pressures, MAPs. You also need to keep their head in a neutral position because you're adding drainage via their jugulars. Now here's where it gets a little weird, is people will say increase the head of the bed, gurney, to 30 degrees. But you gotta watch them like a hawk, because if they start to deteriorate, you gotta lay them flat again. Because you don't want to get intracranial hypotension. So in the field, okay, do I lower their blood pressure? Do I resuscitate them? Do I raise the head of the bed? Do I keep it the same? There's just too much shit going on to adequately do it, I think, in the field. So that's why I've never been a big fan of giving a nitroglycerin for hypertension in the field. You don't know what they're going to do, and it's real easy to go sideways. So ischemic stroke, greater than 120 systolic, not good. Greater than 120 systolic. Those are the guidelines that they're looking at. If they're extreme hypertension, then you can't treat them with thrombolytics. You need to bring them down. But you only do it by what you have to do. The extreme hypertension, again, you're checking these people every 5 minutes. That's not easy to do in the field. So some of these people say a target of 160. I'll tell you what, I'd be happy with 185 over 110, which is the guidelines for thrombolytics and stroke. So the Interact 2 study, these people had a systolic blood pressure between 150 and 200. They acutely lowered it to 140. They used nitroprusside, esmolol. Again, no signs of increased intracranial pressure. Our patient has intracranial pressure that's increased because he's herniating. Because without increased intracranial pressure, you don't herniate. So, some people say 140. I don't. It makes my stomach turn to think about it. So I think the documentation was good. I think the care was good. I think the take-home message are watershed areas, and don't be so quick to treat hypertension. Now, if they're having chest pain and hypertension, that's a different story because they're having ischemia in the heart. So you gotta treat it. So, case number 2. Again, from another LEMSA not nearby. 17-year-old, abdominal pain, dispatched, en route, patient contact, left the scene. Time on scene, they were fast, 4 minutes. Time to destination, 47 minutes. Long transport. Abdominal pain. So the narrative, made contact with the 17-year-old female, was transported to Hospital X. They found her with her mom, complains of abdominal pain. This was after a motor vehicle accident, about a half an hour earlier. Patient was wearing a lap and shoulder belt. Front seat passenger of a slow MVA, 15 to 20 miles per hour, side swipe with no loss of consciousness. So what are people thinking?
Well, the mechanism doesn't really add up. It's a side swipe, but not that fast.
Be doing a normal abdominal assessment, not a trauma assessment.
Okay.
You're gonna be looking more at medical than trauma.
So you're looking medical, not trauma. How about you, Tony?
Just trying to get more history.
Okay, he wants more history. So, mother, who was the driver, fled the scene because they were, quote, scared and called 911. I point out that the medic got this backwards. The patient is a 33-weeker.
Oh, okay.
Gravida 1, para 0. We go through that in the educational piece. She denies spotting and feels the baby move. Has no other means to get to the ER. No new complaints or changes. So what are people thinking now?
Well, it's a problem with her pregnancy, right?
Until proven otherwise,
Right.
in my mind.
Yeah.
Okay. She's on Keflex. She had kidney infection. Airway's fine, breathing's fine, lungs are fine. So we go to circulation. Okay. No edema, good. Neurologic. I would say the neurologic is incomplete. What else would I want to see in that neurologic exam?
Reflexes, DTRs.
Exactly, reflexes. Is she eclamptic? So, this was the end of the exam. There is no mention of an abdominal exam in this PCR.
Really?
Right. I think they got focused on, oh, it's just a low-speed MVA, and didn't say, oh, well, they're pregnant too.
Well, and she's at risk, 17.
She's at risk because she's young. She's at risk because she's 33 weeks. So,
Prenatal care, they didn't ask that.
didn't ask that. So if somebody's pregnant, and
Wouldn't you kind of focus in this?
hey, I don't write this stuff.
No.
I couldn't write this stuff. I just report it. Now you know how I spend my evenings going, oh. Oh. So yeah, the exam's absent and the history sucked. So gravida really means the number of times the uterus has been heavy. Parity is the number of live, viable pregnancies past 20 weeks. So twins technically count as just one pregnancy. So the octomom who has 8 kids, she's still a G1P1. Take that home to the bank.
That's why I use GBTL.
The bottom one, preterm, term, abortions, you know what? That's too complicated for me. If you can remember it, Joey, more power to you.
It really require us to. So.
Last menstrual period, that's key. I've never understood why they call it estimated date of confinement. The EDD is the due date. Quick and dirty rule, 7 days to the last menstrual period, then add 9 months. That's the Naegeli rule.
The Naegeli rule.
The Naegeli rule.
I like it.
So, pregnancy. Heartbeat nowadays is 5 to 6 weeks. You can see it on Doppler. Audible, about 8 to 10 weeks. When I first heard my first daughter's Doppler, the only thing my wife told me I could say for an hour after was, wow. That's all I said. Wow. You can hear a pregnancy at 20 weeks. Viability is at 22 to 24. This was, again, a discussion just recently on the ACEP listserv, talking about what you should try to resuscitate. Fused eyelids, probably not. 22 weeks, probably not. Although there's some work on external artificial uteruses now, where you can, they're experimenting with 3D printing. So you pop the kid back in a different incubator. Amazing shit. Again, normal pregnancy, the uterus is protected up about 12 weeks because of at the umbilicus. It's at the top of the pubic bone. 20 weeks, it's out, and after 20 to the symphysis, right where your solar plexus is the age in weeks. So uterus is intrapelvic at the umbilicus of 20. It starts out as a thick wall, very thin walled. It's less elastic. The reason why pregnant women go into DIC is because it releases thromboplastin and plasminogen. Here's the image on the on the left, where you're measuring the fundus. This is what I did for a month in residency.
You're the official measurer?
Well, they didn't know what to do with ER residents. And so I would go to OB clinic every day, and I'd spend my day measuring uteruses. The glamour wore off after about, the second. So, truth be told, I'd find reasons to leave clinic. I'd go to the library, I'd find a surgery to go into in the GYN side. Now, after hours, I got to do deliveries. But, you know, how hard, look at the image on the left. It's a tape measure with sonometers. You feel the pubic bone, you feel the top of the uterus.
There's the fundus.
There's the fundus, okay. So physiologic changes. Respiratory rate goes up because of progesterone, therefore their CO2 is lower. These patients have a naturally low blood pressure because the blood volume increases, but the number of red blood cells doesn't. Pregnant women have perpetual heartburn because the lower esophageal sphincter relaxes. And musculoskeletally, their bones and joints are laxer. And because they have a bowling ball in front, their center of gravity changes. So they're leaning forward, so you got to think of little kids who run. So the other thing too is pelvic vasculature naturally gets dilated. So minimal trauma can cause exsanguination. So cardiac output goes up by 20%. Holy shit. Heart rates are up to 30 beats per minute higher in the third trimester. The blood pressure naturally goes down, so what may be normotensive in a normal person, if you're pregnant and you get a blood pressure of 130 over 85, that's eclamptic or preeclamptic. Cardiac output goes up again, 1 to 5.5 liters per minute. Here's why you always lay them on their left side, because the uterus compresses the vena cava. Women hyperventilate, tidal volume increases, but the problem is so does the uterus, so you've got competing volumes. We talked about GI, urinary. So there's a huge amount of pressure on the bladder. And you also cause dilation of the calyces and the ureters. Blah. Right greater than left. Don't remember why. Blood volume goes up by 45 to 50%. So if a patient is in shock, pregnant patient from hemorrhage, they're in a world of hurt. RBC mass doesn't go up as much as the volume, so that physiologic anemia is present. Platelets increase. Endocrine system, you don't need to know about Sheehan syndrome. Left lateral position for transport. This is why the baby sits on the inferior vena cava. So ABCs, mom is our first priority. You got to save the incubator. Rebound and guarding is less prominent because of the uterus. Secondary palpation of the uterus. After any trauma, whether it's a slip and fall and they land on their butt, are you bleeding or you have any fluid leaking? It doesn't matter. Any trauma can cause abruption. Any trauma. And you say, is anything protruding from the vaginal wall? That's E. Okay. You never, ever examine the vagina. Oh, I've had people ask, should I do a speculum exam? I said, on yourself? So what happens if you try to do a speculum exam and it's in a placenta previa? Not good things. So here's abruption. It may be evident, it may not. Bleeding, contractions, abdominal tenderness, and pain. And you can see that this is a hidden abruption. Severe injury, 13% have an abruption. Non-severe injury, 7.5%. With direct trauma, whether it's blunt trauma or penetrating trauma, the rate can go up as high as 40% for abruption. So the medic who wrote the chart, yeah, we had a chat. I get lots of compliments from down in other county where I have some services. Abruption following trauma, vaginal bleeding, 80%. So if they say they're bleeding, you should be concerned. If their uterus is tender, they're just having abdominal pain, 70%. So we go from 4/5 to 3/4, and then just about a third start getting uterine contractions. I don't care what the American Heart says. Use as much oxygen as you need. And fetal heart rate, hopefully, is higher than the maternal one. If the maternal heart rate's 160, bad things. So as I said, questions are guaranteed, but answers are not. So we're going to go through the following slides for the test. Take the final exam. You need to get 80%. Save it. And good luck, and thank you, Bill, for getting this all ready. So, when you are evaluating a patient experiencing new onset stroke, symptoms and accurate blood pressure is crucial. Basically, true or false?
True.
Hopefully you all think true. Okay. Answer. True. Gradual decrease in blood pressure for a hypertensive emergency should be accomplished in the emergency department. True or false? I hear one true. Do I hear any other truths?
Yes, I would say true.
Okay, it is true. By the 3rd trimester of pregnancy, the woman's blood pressure has been reduced physiologically. True or false?
False.
It's true.
Oh, 2nd trimester and 3rd it came back up.
It's not significant.
Oh, okay.
Yeah, technically it comes up about 5% at the end. It's really by the end of the beginning of 2nd trimester. It's just easier to remember low blood pressure in 3rd trimester. True. The watershed areas of the brain are at risk for ischemia when you too rapidly reduce blood pressure in a stroke patient.
True.
True. The neurologic exam called doll's eyes or oculocephalic reflex can be demonstrated whether there is a brainstem injury from a variety of causes.
True.
True, it doesn't matter. When evaluating a patient who is experiencing a stroke, part of the evaluation needs to be checking a glucose.
True.
True. Come on. There we go. When giving report to the base hospital, the pregnant patient's parity status refers to the number of viable live births delivered past 20 weeks.
True.
True. While performing the evaluation of a pregnant patient, if you can palpate the uterine fundus at the umbilicus, aka belly button for people like me, the patient is approximately 20 weeks pregnant.
True.
When transporting a pregnant patient, you should always try to transport them in the right lateral position.
Oh,
False, and it's not potion, it's position. I just got my typo.
I thought it was a magic potion.
It is a magic potion. Oh well. It's the left lateral. After any blunt trauma ranging from low speed, MVA, or a slip and fall onto the buttock,
All the above.
the EMS provider should always inquire about the following: pain, spotting, fluid loss, contractions. It's E, all of the above. Thank you ever so much.
Thank you very much.
Okay. I think we covered a huge amount of material. Hopefully everybody enjoyed the run review. I thought that brought up very salient points.